Thank you, and for the opportunity to speak here today. So I was asked to come and talk to you about the role of the pharmacist, and I guess when I started writing this talk, I thought, what do you think the role of the heart failure pharmacist is, or the pharmacist is? And I think that certainly when in my social life, if people ask me what my job is and I say pharmacist, I think most people think that that's what we do, that we dispense medication, we put medicines in tablets in bottles, we put labels on medication. But actually, this role, this dispensing aspect, hasn't been done probably certainly in hospital, but even in community and in primary care for quite a long time, decades even. And this change has come about more recently, in fact, because of changes in legislation. So as the nurses got prescribing rights in 2006, pharmacists became non-medical prescribers. And then we have had lots of national policy, such as the NHS 5-year forward view, and in 2019, the NHS long-term plan, recommending that pharmacists are an underutilised group of workforce that are able to work as independent prescribing practitioners. And so, you know, there's not just one type of pharmacist. If I came up here and told you all about my role, I don't think that would be very representative of what the role of pharmacists it can do in heart failure. There's obviously community pharmacists, there's hospital pharmacists, you've got your practice-based or GP or PCN pharmacists, and of course there's academia and pharmaceutical industry as well. But what I thought I'd do today is just focus on the top three, the clinical pharmacists, and what role that they can have. So just going back to basics, for those of you out there, we do 5 years of training to become a pharmacist, but that's really the start of our training if you're going to be a clinical pharmacist. Nearly all clinical pharmacists have to do a 2-year postgraduate clinical diploma just to carry on and progress through their career. And these days it's becoming much more normal for all pharmacists to become non-medical prescribers. In fact, in the next 5 years, what you're going to see is that pharmacists are going to come out of their degree, and when they finish their 5 years of training, they will already be prescribers. So starting with community pharmacists, I'll hold my hands up. I haven't worked in community since I was a technician over 20 years ago, but they do a really important role, I think, for our heart failure patients out in community. There's very few healthcare specialists that they have easy access to, free of charge, don't need an appointment, and that's why heart failure patients, in fact, any patient utilises and knows their pharmacist in community very well. They often counsel the patient on their changes in medication, new things that have been started, how they take them, but also they do lots of screening services now. They do BP screening, cholesterol screening, they do obesity management programs, and they do emergency services out of hours to provide palliative medication for those that need them. And then more recently, they do vaccinations. So actually, I think the community pharmacists shouldn't be overlooked. They definitely have a role in helping and supporting heart failure patients. Moving on to practice-based or GP pharmacists, I'm not going to stand up here and say again, I've never worked in primary care, but I consulted with Rocco and a few of the other practice-based pharmacists, and what I got from their feedback is that they have quite a varied input specifically into heart failure patients across the region and the country, in fact. This is probably because at the moment, the sort of advent of practice-based pharmacists was about from 2014 onwards, when nationally they funded lots of practice-based pharmacists. And throughout that time, when we've got increasing numbers of pharmacists, there's a bit of a disparity. There's some practice-based pharmacists employed by GPs, some are employed by the PCN, some are employed by the medicines management teams, and they all have slightly different targets that they're supposed to deliver. But what came across from my conversations with my colleagues was that they definitely support QOF targets for heart failure patients, making sure that they're coded appropriately in GP practices, and they undertake structured medication reviews or SMRs, and these are where they target patients who are on polypharmacy, at risk of AKI or falls, and they can often reflect the heart failure population. But what became clear from my conversations with my colleagues is that actually that's an untapped source that potentially could support heart failure patients more so, and I'll come to that in a little while. So back to what I know best, and that's hospital pharmacists. And like doctors and nurses, we have different grades, but essentially all pharmacists in hospital play a part in managing a heart failure patient. They at least make sure the patient is on the right drugs when they come in, that throughout their stay they make sure that the treatment they're on is safe and effective, and then they support that discharge process, making sure that's managed appropriately and transfer the information to the GP. As they get more specialist, they'll attend ward rounds, prescribing perhaps, and be involved in formulary and guideline development, education. But when you start thinking about true heart failure specialist pharmacists, there aren't very many of us, and that's something that perhaps is going to change, I think, in the coming years. So to become a heart failure specialist pharmacist, you need to do those extra qualifications that I think Carolyn talked about. Just like the nurses, it's not appropriate that to say that all pharmacists can come out and do this job. We can do it. We just need additional training like the doctors and the nurses. So, for example, they should all do clinical examination. We should be able to do full cardiorespiratory examination. We should do advanced communications. We can break bad news, do an ECG course, and at Chester we make sure that all our team, nurses and pharmacists, do the postgraduate clinical diploma for cardiologists specialists. But some of my colleagues across the country have decided to do the research route, so masters or PhD. But what is really critical is having that ongoing mentorship from cardiologists or GP specialists to make sure we learn with everything that we do. So I'm not going to labour this point. I think, what does the heart failure specialist pharmacist do, whether it's in our clinics or on the wards doing ward reviews or ward referrals? It's essentially the same as what the heart failure nurse does. We take all the information from the results of the test, look at the notes, look at the bloods, look at the chest x-ray, do a full cardiorespiratory examination, look at their observations, and then pull all that together to get a diagnosis after talking to the patient, looking what their NYHA categorisation is. And then we talk to the patient, we counsel them on their diagnosis if they don't already know, and then we get an agreement between patient and pharmacist about what treatment is right for them. And then I guess the additional thing that we try to do as pharmacists, because we are supposed to be experts in medicine, is consider all their treatments, not just their cardiac treatments. So I'll look at the patient. We tend to get referred the more complex, multi-morbid patients on multiple medications, make sure that all their other non-cardiac medications are safe in their cardiac condition, and equally ensure that any other comorbidities that they have isn't problematic for the heart failure treatment that we're starting. And as I've alluded, there are other specialist heart failure pharmacists across the country, both in Scotland, Wales, Ireland. We've got a really good network now, and numbers are growing. But locally, we are quite fortunate. We have some local services that include a heart failure specialist pharmacist, and I'll talk to you a little bit about Rocco's team up in South Wirral. So Rocco was a specialist heart failure pharmacist over at Wrexham Heart Failure Community Team, and then moved to the Wirral and is now lead PCN pharmacist at South Wirral. And because of his expertise, he's applied that within the PCN network. He provides training for GPs, practice nurses, pharmacists and technicians. He has got involved with the discharge reconciliation process to ensure that every patient that comes into hospital and is diagnosed with heart failure is then coded appropriately when they go back to primary care, and then does a post-discharge heart failure clinic review. And he's upskilled his practice nurses and pharmacists that they can do a safe and effective annual heart failure review, so they're complying with NICE guidance. And he's developed a template to be put onto EMIS, which makes that review consistent and safe. At Chester, we have a really good MDT. I'm not going to go through all the names of these, but we have specialist nurses. We've got our eminent leader, Antonios Spanopoulos, and we've got me and Will, two specialist pharmacists, as well as the community heart failure team and cardiac rehab. And we do a weekly MDT, and that also now includes Professor Frank Joseph, who's an endocrinologist, so that we can discuss SGLT2 patients who have diabetes. And we also include Wrexham Heart Failure team as well. We do inpatient reviews of all heart failure referrals, so patients admitted in acute heart failure or who are known heart failure. And we also do day case IV diuretics and IV iron. The nurses do a nurse-led diagnosis clinic, so direct access via BMP and ECHO, direct access ECHO, and we have the pharmacist-led clinics as well, and we all contribute to the NICOR audit. But because I was asked to focus on the pharmacist role, we do 3 heart failure clinics per week, 2 urgent heart failure clinics. They're designed to try and facilitate early discharge and prevent readmission. And they've been really quite crucial, I think, in getting referrals to do the 4 pillars as quickly as possible. I'll get referrals from cardiologists, sometimes from LHCH, to make sure that we're seeing patients as quickly as we can. I also do 1 routine cardiology follow-up clinic, and that's to assist with the cardiology queue. But obviously our job is to get them on key drugs or refer them on for IV day case diuretic, admit them if they need to, and that will include HFrEF and HFpEF patients. And we do have the potential next year of developing a business case to try and pick up those patients out in primary care, currently not under a cardiology service or heart failure service, and would benefit from an SGLT too. So the role, the role is the role that you expect perhaps a heart failure nurse to do in the hospital. We're very much interchangeable. We look after each other. We do cross cover. There's no specifically defined pharmacist role. We definitely work as a true MDT, as opposed to having a particular stream of patients that the pharmacist sees. But there are other roles of the heart failure pharmacist, and I just wanted to point those out. Do national work, working on NICE scoping workshops, involved in clinical trials, so I've been principal investigator of the ISCAMAT study, do a lot of teaching and lecturing, for example, at the BSH, and we get involved in NICOR, and of course, guidelines and policies. That feels like your bread and butter, and as Stuart said earlier, constantly changing, having to update, particularly with heart failure. So hopefully I've given you a picture of what pharmacists can do at the moment, what they are doing, but what can we do more? And I think what's come across to me is one of the NC pod recommendations was that every heart failure team should have a pharmacist integrated into that team. And that supports the NICE statement that you should have an expert in specialist who prescribes in heart failure, and arguably I would say that would be a pharmacist. We don't have enough cardiologists, we don't have enough specialist nurses. I think it's an untapped potential resource that we can work together to make services better across the country. And we certainly need to train more heart failure specialist pharmacists, but also talk about training, primary care, more generalist pharmacists to manage the stable heart failure patients out in primary care, to support the GP practices to ensure they're doing annual reviews, making sure they're coded appropriately, making sure that they're on the heart failure treatments that they should be on. But to do that, I think we need further training, and that's something that Rocco and I are going to be looking at nationally to try and get some more important training for primary care pharmacists to manage these patients appropriately. Perhaps they could be responsible for following up and initiating those SGLT2s once they're recommended by the specialist team, and certainly to make sure they're not stopping the right heart failure medication that specialist teams have put them on. We want to avoid them being stopped when they go out to primary care. So to summarise, I hope I've given a quick overview of different roles of pharmacists and how many of them can have quite a significant impact on managing heart failure patients. We do need more training, I think, out there in practice in primary care, and that's a potential untapped source that perhaps we can look at to help support those teams, services out there that are already struggling with the capacity that we have to deal with. But the main thing is that we work better as a team, and we're just part of that multidisciplinary team to make things better. Okay, thank you.